Welcome to audio highlights for Chapter 18, Multicultural Diagnosis and Conceptualization. This chapter primarily focuses on the field of psychology, but broader than that, also mental health and some problems that our field has had in terms of merging the information that we have on multiculturalism with our current way of practice and the way that we assess people and then eventually diagnose them and treat them. So we look at this as a huge challenge in terms of an ethical challenge that we need to conduct culturally unbiased or multicultural assessments, and to do that we need to have a cultural framework to go under. So we need to understand the cultural meanings of things like functioning and social relationships and family relationships. Primarily our field uses the manual, the Diagnostic and Statistical Manual of Mental Disorders, so the DSM system. That's the way that we define diagnoses and the way that we also look at things in terms of symptoms, and eventually it's what guides treatment. So there's been a lot of criticism around the idea of that the DSM itself is not very culturally competent, and so therefore it trickles down and you see problems like overdiagnosis, underdiagnosis, and misdiagnosis, and also just poor assessments that don't give us a accurate way to measure people's symptoms without also becoming tangled up in cultural practices. So the DSM itself is based on the question of what's normal and what's abnormal. So we ask questions like, who gets to decide what's abnormal? We want to be very careful that we're not defining abnormality just on the basis of if it's different than what the cultural majority is doing. And so we also really have to think about context and situations. And an example of that is that if you're outside a building, or maybe you're outside a McDonald's waiting for your food, and all of a sudden you see a person come running out of the building with their hands in the air, running across the parking lot. So if I asked you if that behavior was normal or abnormal, then if you just looked around and you didn't see anybody else acting like that and you couldn't really get any clues as to why, then you might decide that that was abnormal. If you later learned that there was actually a fire in the building, or that the person maybe had just been robbed in the doorway or something. So there might be a situational aspect or a cultural aspect that we don't know at the time. And so without knowing the whole story, we can't just look at a behavior and determine if it's normal or abnormal. And that's been a huge criticism of the field for quite a while. Again, I mentioned that the problems that we're trying to look at in this chapter are overdiagnosis, underdiagnosis, and misdiagnosis. And when these types of bias occur, whether they be based on stereotypes or because somebody differs from the norm, the problem with this is that then our treatment is misguided as well. So people may not be getting enough treatment or the treatment that they need, or they may be getting treatment for something that they don't have. So that's something we want to avoid. Sampling bias has also been a prevalent problem within the field of psychology, in terms of that the vast majority of treatments and assessments and even the way that we measure symptoms are based on samples that primarily were made up over in the history of white males. And so we have this biased sample that kind of forms the base of assessments that have been used for decades, and the way that we treat certain diagnosis. And so the problem with that is, do we ask ourselves enough, is this relevant for people of color or for women of color? So we really need to make sure that our samples are more diverse, and that we are including a diverse sample not only in our research but also in treatment, and then on research of the treatment itself. I think I mentioned that culture and psychopathology sometimes can be very difficult to untangle. So we know that culture allows individuals to define, express, and interpret their beliefs, values, and customs. And so we need to look at research in a cross-cultural way. And the DSM very much represents Western thoughts and assumptions, so we need to always be cautious and remind ourselves that it doesn't include culture-specific psychological problems. So it does include that actually in the appendices, but they're at the end of the manual and they're not woven into. One of the criticisms is that some leaders have said in the field that wouldn't it be great if that information was included within the DSM itself, not as an appendix, but are there culturally specific things that we need to know for these different disorders? So that may be a goal for the future DSM. Revisions, which they do update them every few years. Your text actually talks about the DSM-4 TR. More recently, the DSM-5 has been released, so the field itself is kind of making the transition to this new DSM. And some cultural aspects have been improved, but many advocates believe that there's still a long way to go. I want to encourage you to review the sections of this chapter on the feminist challenges. So the idea that feminist theorists challenge that Sometimes women's depression or discontent has been reframed as a psychiatric or medical symptom. So this can lead to the overdiagnosis or misdiagnosis of women. And remember that feminists are not just pro-women. They're more about equaling the playing field or leveling disparities. So feminists are by no means all women. It's just a belief system that says that there shouldn't be differential treatment based on gender. So most culturally competent males also identify with many of the tenets of feminist theory. So that's an important clarification to make that I think many students miss out on. So we talked a bit about sex bias and diagnosis, and actually that can go both ways. So we've talked some about that females are more likely to be diagnosed with mood disorders, anxiety disorders, especially borderline personality disorder. Many women who have experienced abuse or trauma are labeled with that. It may or may not be accurate, but we need to be very careful to make sure that we understand the effects of trauma versus misdiagnosing the effects of trauma as a personality disorder. Males have higher rates of diagnosis for substance abuse and sexually related disorders, so there's also some skews there in the rates that they're diagnosed with personality disorders like passive aggressive personality disorder, which was kind of a lesser used label, but then compared to antisocial personality disorder, which is one that many people in our prison system, many males, have been identified with. So we always just need to question, why are there these large differences in genders with diagnoses? And whenever we see those differences, we need to ask ourselves, is this more of a cultural aspect, or is our field kind of pathologizing certain gender traits or tendencies? So I really like this chapter also includes, while bringing up the many problems that we have, it also talks about some solutions. So the idea that we need comprehensive assessments that are culturally competent, just what you've learned in this course this term, we need all professionals to have this knowledge and be up to date on it and to be fresh, so that we can ask questions in a culturally competent way, and so that we can be aware of our own beliefs. We should explore our own cultural values and beliefs and systems and structures, so that we can be extra careful to make sure that we either keep those in the room in a way that doesn't impose on other people, or what I would call out of the room, meaning that we don't want to impose our personal views on the people that we work with as a professional. So as we work with different kinds of people, we need to be very aware of the types of emotions that a particular cultural group might experience, and we need to learn about how does this cultural group express their emotions. So are there different times and places and people that have kind of different social rules or norms, and those differ by culture. So we need to assume that there are going to be these rules and that they are different, that we don't need to only line them up with what our westernized beliefs might be. As we assess our client's cultural identity, we also need to assess our own, as I discussed, and we need to avoid that personal bias, and we need to plan treatments collaboratively. So thinking about working with a client, not on a client, or even for a client. We need to work together. Seems to be the most effective way to deliver culturally competent care. And finally, we talk a little bit about how the DSM has evolved over the years in terms of becoming more relationally oriented, which is really helpful to better address the needs of people who have a collectivistic way of being, rather than just the individualism that sometimes dominates our Western culture. So there have been some expansions in the previous DSM that I mentioned, the DSM-4, that V codes were used, where as a part of a person's diagnosis, you could list problems maybe with relationships, or if they had a lot of sibling discord as a child, you could list that, or if a person was going through a divorce. So that's always very helpful to know if you're trying to understand a person's full functioning. And in the revision of the DSM, those were actually removed, so it will remain to be seen how the DSM, this new revision, will do in terms of providing culturally competent care, but it's definitely a goal that the field of psychology and social work and other human services continues to work towards.